Thank you so much. I thank Dr. Soumya Nambiar to involving in this very important session. After a fantastic talk, I think being a private practitioner, sir has given in between a lot of jokes, and in between he has told about what kind of all spectacles. It's hats off to you, sir. I think I have not seen this kind of talk by any of the ophthalmologists in All India Ophthalmological Society talks. Yes. Thank you, sir. So, Dr. Soumya wanted me to talk on optimizing biometry to avoid refractive surprise. No financial interest. So, what exactly is the biometry? It is a measuring of various dimensions of the eye, its components and their interrelationships using data to determine the ideal intraocular lens power. So, meter, autokeratometer, even keratometry can be incorporated into the IOL master or lens star, or even you can get the keratometry from the topography, whether it is a placido based or elevation based maps. So coming to the manual keratometry we used to do in our time like 30 years before, the principle is simple. It's on the fixed object and the variable image size with a fixed image and the variable object size. So the most common one is the Boschon lamp one. So coming to the autorefractometer. So the keratometry in autorefractometer also very accurate because it measures the 3 mm zone. What exactly is the principle? It focuses the reflected corneal image onto an electronic photosensitive device which instantly records the size and computes to the radius of curvature. So coming to the axial length measurement, you can do with two equipment, either with the optical or with the ultrasound method. So coming to the ultrasound A scan, most frequently done by all of us, the principle is ultrasound probe has a piezoelectric crystal that electrically emits and receives the high frequency of sound waves. So normally what happens, the measurement is from the anterior corneal surface to the internal limiting membrane of the retina. So if you make a 1 mm error, that means there is an error of 2.5 diopters post-operatively. You have to be very, very careful, and 50% of the surgeon's post-operative surprise is A scan error. So what are the tips for accurate axial length measurement using this method? First, make sure that machine is calibrated very well. Always you should look for the echoes from the cornea, anterior lens, posterior lens and retina should be present in a very good amplitude. Normally average of 5 to 10 are most consistent result giving a lowest standard deviation. So average has to be between 5 to 10. Misalignment along the optic nerve is recognized by always a absent in the scale spike. So if you can see here, A is the initial spike where probe tip and the cornea, B is the anterior lens capsule, C is the posterior lens capsule, then retina, sclera and F is the orbital fat. So what are the uses of gain in difficult situation? So especially you have to increase the gain whenever there is a dense cataract. So when you do with the dense cataract, you increase up to 100%. Or you have to decrease the gain whenever you are doing a biometry in a silicon filled eye. So you have to ask the patient whether they are operated for retina surgery or not. So coming to the most accurate ultrasound method is the immersion technique. Normally patient has to be in the supine position, or even he can perform with the standard ophthalmic chair that is reclined at 45 degree, normally by the help of a positioning shell or Prager shell. So what are the limitations of this immersion you have to do? I think everybody will tell you do immersion, but you have to be very important. The study shows that when you take an 18 out of 34 sample, there are positive organisms grown in this positioning or Prager shell. So you have to be that sure. So the best recommendation, this shell and the probe should be soaked in alcohol or hydrogen peroxide for at least for 5 minutes. Then you have to allow it to keep it for dry, then flushed with a BSS solution. This is very, very important for prevent any of the infection to happen. These are the difficult situation when you are doing with ultrasound. That is, in the case of low vision, patient with nystagmus, blepharospasm and strabismus. So one or two point about the posterior staphyloма, because it has got a irregular shape of the ocular wall. So when you are doing the scan, normally you will have a high retinal spike. The deepest portion of the staphyloma may be located eccentric to the macula. So thus the measurement may be longer than the true axial length along the visual axis. This is very, very important when you are dealing posterior staphyloma. I do remember I did a scan with the posterior staphyloma. In spite of optical biometry, I have to reoperate 2 times. So as I said that silicone oil, you have to decrease the gain. So let me come to the optical biometer. This was the initial optical biometer, that is IOL master was the first optical biometer 500, which is based on the partial coherence interferometry. Later comes the lens star based upon the low coherence optical reflectometry. Basically in the IOL master 500, number of points tested are 6 points, and in lens star it used to test around 32 points. So compared to the IOL master 500, lens star was better. But now comes the latest one, is the IOL master 700. The basic principle itself is different. It is based on the source OCT. So it gives a much better result because it measures the axial length along almost in 0.4 second and designed to measure the axial length along the visual axis. It also uses the lateral slit illumination of the crystalline lens and the cornea to determine the antechamber depth, and autokeratometry to estimate the corneal curvature. But very important, it also measures the posterior corneal curvature. If you see, I think what are the machine which really measure the posterior corneal curvature, you use the accurate biometry because of most of the new IOL formulas which is with the posterior corneal curvature. So you need to look for equipment which can even look at the posterior corneal curvature. So these are the advantage, especially because of when you are doing with a very thick PSC and all, IOL master 700 bypasses over IOL master 500 or even over the lens star. But there are limitations with IOL master 700 also, that patient has to look straight. Whenever it even takes in a mature cataract with a very dense mature cataract grade 4, sometimes it will not measure. But of course it is very expensive, you have to keep it in mind, it is almost double the money. So let me come to the one or two words about the IOL formulas. The first generation was the SRK1, Beacon. Second generation then becomes the SRK2. Then third generation has become like SRKT, Holiday and Hoffer Q. Now we are with the fourth generation, Holiday 2, Aegis and also Barrett's 2 formula. So normally this theoretical formula based on the mathematical principle revolving around the schematic eye. Then comes the regression formula which is working backwards on the post-operative outcome. But this third and the fourth generation is a mix and match of both theoretical and regression formulas. So coming to the one or two word about the SRK formula, which gives a good results between the axial length between 22 to 24.5, because normally it works well within this range of 22.5 to 26, because they normally A constant computed based on the average axial length of 23.5. This is my assumption. So this is about the SRKT formula. Normally Holiday 1 works on the surgeon's factor, Holiday 2 on the ECD, Hoffer Q on the pseudophakic ACD. So Haig's formula most useful in the long eyes. Coming to the Holiday 2, most of us been using most sophisticated formula because of these reasons. It takes 7 parameters into account. One is axial length, AC depth, central corneal power, lens thickness, white to white, age of the patient and the previous refraction. But you have to keep it in mind about the effective lens position. So as you know that in any dual system, if the primary lens and the distance of the screen are fixed, then the effective power of the system will be depend upon power and the position of the second lens. This is also very important. What are the factor affecting effective lens position is axial length, limbal white to white, pre-op ACD, lens thickness. I will not be talking much about all these formulas. Special case, post-refractive surgery AL power calculation is also very important. But I don't have much problem with this. But since those who are doing with the ultrasound, you have to log into the universal Barrett 2 formula, put the preoperative this keratometry reading, then you can come out with a very good result. But now most of the formulas like coming in the IOL Master 700 only, post refractive, go to that formula, then you will get the power straight away. So one more last word about the toric IOL calculation. Whenever you are doing, please I am telling you, whenever you are counseling the patient, look at the keratometry reading, you talk to the patient. The treating astigmatism is very, very important. Patient will not be happy more than one diopters of astigmatism. You have to give all patient option to get rid of their astigmatism, whatever the residual level in the cornea. So if the patient is not affordable, then up to your call, but astigmatism control is so important. In conclusion, due diligence has to be undertaken during the biometry to prevent post-operative refractive surprises. A proper history and use of optical biometry and specific formula is at most importance. In customization of cataract surgery, biometry is very, very important. Once again, I thank Soumya and the whole KSOS for this opportunity. Thank you one and all. So, we just keep discussion because biometry is so important. Normally when PGs and all the fellows join to us, they make a mistake. In the end, we have to face the music when the patient comes to us with them. There are some cases which is unavoidable, like posterior staphylococcus. We have to tell the patient about the guarded visual problem. But biometry has to be that good. Of course, if you have got a very good optical biometry, IOL Master 700 or any of the higher end biometry, then I think you can offer a very good premium lens to the patient. Thank you.
Thank you. Thanks a lot. So next we move on to the next session. We have here Dr. Anil Radhakrishnan, who is the head of the Department of Cornea at the hospital Kochi. He will be talking to us on refractive procedures prerequisites. What do you say?
On the last day of the state conference. Quite interesting. Okay. So I thank Dr. Aditya, Dr. Soumya and the chair, Dr. Krishna Prasad Kudly, for giving me this opportunity to speak to you in this platform. So I'll be trying to address corneal topography used, and as biometry, if you make a mistake, your refractive surgical patient would be very unhappy. So I don't think in the 10 minutes I can be covering all the components of the refractive workup. So I'll be just confining myself to topography. And that too, I may not be able to cover it completely. So first I'll tell about the principles. If you look at this picture here, you can see a series of buildings over there and the waterfront, in waterfront which is in the forefront. So if you look at the image of the buildings there, if you see almost everything is like a mirror-like reflection. But if you look at the antenna of these, you can see that there are imperfections here. Why are those imperfections present? That's because there are imperfections of the surface. So that is precisely the principle of topography, that your cornea acts as a convex mirror. In this scenario, in this scenery, you are seeing it as a plane mirror. The cornea, one advantage is that you are seeing it as a convex mirror. And also, if you know the size of the image and size of the object, actually you can calculate or reduce the curvature of the surface. That is the essential principle of keratometry as well as topography. So cornea is a convex surface, and actually the images are magnified. So the minor imperfections that you have would be magnified. The disadvantage of keratometry is that it measures only a very small central area, only 2.5 millimeter area, and it makes a big assumptions that cornea is a symmetrical spherocylinder. So in a normal shaped cornea, it works perfectly well. But if you have an abnormal cornea, that is not happening. So in this video keratoscopy, you have this multiple illuminated mice that are projected onto the cornea. There are multiple video cameras which can take the images of the reflection on the cornea, like the central one is there, two on the sides, and the relation of the point to the central fixation point is taken. So, and the calculation is based on multiple different type of algorithms. So along one ring you have about 256 points. So this I'm talking about Placido topography, and that what we have is the Atlas. Some of the systems may be slightly different. The number of illuminated mice may be more, but essentially the principle is the same. So based on these algorithms, the computer gives a gives a color coding to the data that is there. So you have to look at basically the numbers below. You have to look at the K values, the steep value and the flat value, average keratometry, then cylindrical power. Then there is something called SRI, surface regularity index, and surface asymmetry index. So I'll be just touching upon it. But I think it's very important to realize that these color codes, there are certain gradations for the color codes. Say between 35.5 to 50.5, you have a variation of color only at 1.5 diopters. So if it's a small variation and it's only 1 diopter astigmatism, so you may not see much of a color change. Beyond that, you have about 5 color change occurs in every 5 diopters. So it's very vital that the patient is aligned properly. The lateral candle should be aligned to the lateral candle marker. And when you have a good keratograph, there is only minimal shadow. There are no dry spots. You can see the rings all around. So you have to look at this before you to procure the image or you save the image. That's very important. There should not be any pooling of tears, and the ring should be actually continuous. So this is one patient in whom there was like dryness. You see that there are discontinuity in the rings, and because of that the corneal surface is taken as bad. If you have pooling of tears, what will happen? You will have inferior steepening like this. So, but the position of inferior steepening will prompt you to say that this is usually a problem. So if the patient is tearing and there is pooling of tears like this, you can see inferior steepening like this, which can be a misrepresentation. This is a keratograph I have taken asking the patient to look up. So if the patient is not looking straight, so you look at the right eye, whenever you're taking the image, you have to go back and look at the keratograph. If you see that the patient is looking up and the image is coming like this, you can see that the cornea on the right hand side is totally abnormal. Why is it so? Because it's only a problem with the faulty capture, nothing else. So there are certain abnormal patterns that we see, and there are certain normal patterns also. And there is a gray area between normal and abnormal. It's not black and white. You cannot say for sure that one is abnormal, one is perfectly normal. So that gray zone is quite high in topography. So I'll just go to some of the images. This is one topography of a patient who has about 1.5 diopters of astigmatism. You can see that there is a bow tie-like pattern. This is the superior steep pattern. The superior cornea is slightly steeper compared to the inferior cornea, but that again can be perfectly normal. So astigmatism is generally symmetric. You look at the two bows of the tie, that will be symmetrical. There will be something like an hourglass or a bow tie shape. And it can be with the roll, it can be against the roll, it can be oblique also. But if it is grossly asymmetric, then you know that there is a problem. Usually it indicates a pathology. So that is it. So the other thing that is important is the asymmetric bow tie pattern. If you look at the two bows of the tie, they are in one line and they are symmetrical, as I said before. If it is grossly asymmetric, and if the bows of the tie are not in one line, there is something called a skewing of radial axis. Very minimal skewing can be normal, but if it crosses 12 degrees, and definitely if it crosses 20 degrees, that is definitely pathological. A normal cornea cannot have a pattern, topographic pattern like this. So this is my own topography. I have done this. I have astigmatism with the roll astigmatism. You can see that the superior part of the bow tie is slightly more steeper than the inferior part. What about this? This is you can call it an irregular pattern, but absolutely no pathology seen. We have to look at other parameters also. So when you see a patient like this, you see that there is a small amount of steepening, and that is remaining in only in one small area, paracentral area. So this, just go back to the keratograph, repeat the topography. Maybe you can put a lubricant or ask the patient to blink a few times and then do it. Lubricant has a problem. Sometimes it will iron up these small defects that are there on the cornea. So actually you should ask the patient to blink a few times and then repeat it. If still it is coming abnormal, then only you go for the lubricant. That's what I do. So you ask the patient to blink a few times and take it, it's perfectly normal. So it's absolutely normal. So keratoconus is characterized by asymmetric bow tie pattern, as I mentioned before. There can be gross asymmetry between two eyes. In one eye, it it can almost just be normal, or we can say small hint of inferior steepening in one eye, and other eye can be very, very high keratometry values, the gross red colors you see here. So whenever you see these red colors, you should look at the corresponding keratometry readings below. For example, you look at this color, the color corresponds to around 50, more than 50 definitely. So this is what you should look at. Just because you see a red color, the scale can be different. Sometimes 45 may be shown as red also. So you should look at the color and the corresponding value there. Then only you can correlate. So this, I don't know, it's coming again. So I don't think I'll go into the details of this, but we have other systems with which the thing what I spoke about right now is only about the anterior corneal curvature. There are other data also which can be derived with a newer machine. This is the Visante OCT machine, in which the first image shows the anterior curvature data. Then you have the pachymetry, both absolute as well as relative pachymetry data. Then there is elevation data. So based on all this, you know that it is abnormal or normal. So this is a patient who came for a premium IOL surgery. Actually, this is a patient who had a keratoplasty some 20 years ago. And he asked whether it is possible to do a multifocal IOL. So what do you think? So if you look at the central 3 millimeters of the cornea, you can see multiple zones there. One area it is, the keratometry is coming to somewhere around 24, 25. Here it is coming to 45. Here it is 42, 43. So it is a very abnormal cornea. So he is not a good candidate for premium IOL. If he badly wants it, you can ask him to take it, but at his own risk. But definitely, he can assure him that he is not likely to have the full advantage of multifocal IOL. What about this? This is a perfectly symmetrical bow tie pattern. Slightly oblique, but it's perfectly normal. Usually very likely to have excellent results after surgery. What about this? This again, there is some, he does not have actually the K values are well within normal limits, but you can see that if between the two halves of the cornea, it is not perfectly symmetrical. So you can, like if the patient wants, he can go for a premium IOL, but you have to caution him that the result may be suboptimal. Okay. The other conditions like contact lens induced warpage, it was typically seen with rigid gas permeable lenses, but nowadays very rarely used because of the proliferation in the lens market, and it is characterized by inferior steepening exactly in the inferior location. Even soft contact lenses can cause imperfections. Like this is a patient who came for LASIK workup, found that there is some irregular pattern. So the Kudly software was telling that there is a keratoconus suspect-like a pattern. But if you see the keratograph, there are imperfections there. So I just put the patient on lubricants, and after 2 weeks, 3 weeks, it was consistent. And even the pendicam was normal, so we went ahead with the procedure. Sometimes you can get a descended ablation, and in such, like in a perfectly done LASIK, the area where it is ablated will be right in the center. It will be encompassing the central 3 millimeter area. So if it is tilted to one side, there can be glare and halos to the patient. So more importantly, it's useful for you to understand that it's because of the decentration. In keratoplasty again, we can assess the suture thickness, suture tightness based on it. Like if you see that there is a pattern like this, you know that the suture here is tight and you can remove that. I'll just mention about OpScan and Pendicam. I don't think I have the time to do it. But in this, there is, in all this, while what I was mentioning was about corneal topography. Now, with the advent of OpScan in 2000s, and now we have Pendicam, Sirius and other imaging, you can have a look at the curvature of the posterior curvature also, and you can have a good assessment of the thickness of the cornea also. So it keeps a best fit sphere and look at the points which are above it and which are below it, and based on this the images come. So you have an anterior float, then you have a posterior float, you have certain normal values, and if it is beyond that normal values, you have to consider it as abnormal. Obviously you have to go look at the axial curvature map and the pachymetry map also. If it's time, just let me know when you have crossed the time limit. Is it over? Yeah. Okay. So I'll cut down in the interest of time. Thank you so much for the opportunity.
Thank you, sir. It was a because it takes more than for us to know only 3 to 4 months to know about all these maps. Once again, I thank. The only thing is, sir has shown, which is the basic for it. That is the anterior topography when it's combined with the visual OCT, which also gives a.
Now I invite Dr. Dinesh B. Chandrasekharan, Consultant Vitro-Retina Department, Prasad Hospital, to talk about electrodiagnostics.
Okay, I would like to. Are working or studying at institutes which have ERG, etc. Please raise your hands. Okay, very few people. So it's a vast topic to cover in a short time. I would just tell you about basics of electrodiagnostics and how to do it. We'll not go into much details because it may be too complex. So first of all, what are the common electrodiagnostic tests performed? They are the ERG, pattern ERG, multifocal ERG, EOG, and your VEP. Pattern ERG is a little variable, so we don't use it very commonly these days. Other tests are very commonly used. So basically all electrodiagnostic tests are the measurements of retinal or cortical responses to light. So these are measured by electrodes, which is processed by a biosignal amplifier and then displayed on a monitor, and which is analyzed by a software and displayed onto a monitor. That is the basis of all these tests. ISCEV is the international body which formulates protocols and standardizes these tests throughout the world. So you have to follow ISCEV protocol while doing and even interpreting these tests. Coming to electroretinogram, it is the global response of the retina to light under light and dark adapted conditions. Basically, you put light into the eye and then record the electrical potential that is generated. So it is best measured with contact lens electrode directly on the cornea. So basically, the ERG has a Gansfield stimulator, the electrodes, amplifier, and then a display system. So Gansfield stimulator has stimulators as well as your fixation lights and everything incorporated into it. So it can be measured by different kinds of electrodes. Most commonly used ones are your Bury and Allen electrode, which is a contact lens electrode, and other electrodes are your ERG, JET, DTL, etc. So ISCV recommendation for full field ERG is basically you have to keep the patient in the dark for 20 minutes and then measure these 4 responses. First of all is the 0.01, this number here, 0.01 tells you that that is the luminance of the flash that you are giving into the eye. So that measures the rod response. Then you increase the luminance to 3. So that measures the combined response of the rods and cones. Then you give the same flash again, then measure the oscillatory potential. Oscillatory potential is measured by the machine by using a band pass filter. So basically it is the same response, but the waveform is finally filtered to give you the oscillatory potentials alone. And 10 flash is used to measure the same standard combined response. Then you put the patient in normally lit room for light adaptation for 10 minutes, and then you give the same flashes again. So that will give you the single flash cone response, and then you give him a flicker of light stimulus. That is your 30 Hz flicker, means you will get 30 flashes of light in a second. So, and that measures your cone, that also is a measure of your cone function. So the origin of the ERG waveform, the ERG has an initial negative deflection called the A wave, and then a positive deflection called the A wave. A wave is a function of the photoreceptor cells, and B wave is mostly from the molar cells and the bipolar cells. And the oscillatory potentials are said to be from the amacrine cells. And the implicit time is measured from the onset of stimulus to the peak of the or the trough of the A wave, and B wave implicit time is from the origin to the peak of the B wave, and the B wave amplitude is measured from the trough of the A wave to the peak of the B wave, and A wave amplitude is measured from the baseline to the trough of the A wave. So this is what a normal ERG looks like. The rod response should look like this. It should not have an A wave, it should have a positive B wave alone. And the standard combined response should have a nice A wave and a B wave. The B wave should be larger than the A wave. The oscillatory potential should have 4 peaks at least. And single flash cone response should have an A wave and a B wave, just like your standard combined response, but the amplitude is slightly lower. And 30 Hz flicker should have a sharply rising peak like this. So this is what a normal report of the ERG looks like. So how to ensure reliability of an ERG? The electrode should be cleaned regularly and the positioning should be very correct, and the fixation has to be ensured. In patients who have very low vision, we have to ask the patient to look straight ahead, and the flashes have to be calibrated occasionally with the photometer separate from that of the machine. You have to make sure that the flash that is actually being delivered into the eye is of the correct luminance and intensity. And repeating the responses and then averaging it will reduce the effect of background noise. And interpretation, I will not go into much details. The indications for ERG are mainly for diagnosing and prognosticating inherited retinal diseases. So in the case of retinitis pigmentosa, it would be flat. In cone dystrophy, the cone responses would be flat, whereas the rod responses would be normal. Another test is your EOG, which is a measure of the constant standing potential of the between the cornea and the back of the eye. It basically tests RP layer function. So basically you put electrodes on both nasal and temporal side and a reference electrode at the forehead. And you ask the patient to look at the fixation lights which will flash on the left and then to the right. The patient has to look alternately to each, only when the light flashes. So it gives you 16 to 20 sweeps per minute. So first 5 minutes is for practice, and then for 15 minutes you keep the patient in the dark and in the dark, and you measure the dark trough. So basically the amplitudes go down and reach a trough called your DT. And then you switch on the light and again measure it for another 15 minutes. And the responses gradually increase to give you a light peak. And you measure the ratio between your light peak and your dark trough, and that gives you an Ardens ratio. More than 1.8 is said to be significant. So it is mainly useful for your Best disease. Best disease gives you a subnormal value for Ardens ratio. Your head position must be very important. You should ask the patient to move their eyes only when the fixation lights change. Patient should not anticipate the light coming on and move directly. And this practice session is very important before actually doing the test. Otherwise, you can get erroneous results. And your multifocal ERG, I'm not going into much details. It is similar to your HFA. So there is a sequence that is given to the patient, and patient has to fix at the center, and the machine will stimulate the eye and then measure your responses. So the stimulus pattern that is usually given is your 61 or your 103. Most commonly used is your 103 hexagon pattern, covering the central 25 to 50 degrees of the visual field. And you measure the ring responses from each ring, from the center to the periphery. So this is what a normal multifocal ERG looks like. This is your waveform pattern in the center, and this is your ring responses, and this is your topographical map that you get from the responses. So mostly we look at the topographic map, but for reliability and all, you have to look at the waveforms also to see that all these waveforms have a negative P1, negative N1 and a positive P1. So this is a case of HCQ toxicity wherein you can see a clear dip in the parafoveal area. So you have to ensure that the patient does not undergo any fundus photography or any other fundus examination at least 15 minutes prior to actually doing the MFERG. The room should have a normal ambient light and fixation monitoring, just like in your HFA or anything, it is very important. you can use the artifact rejection algorithm which is built into the machine to reject artifacts. There are some common artifacts that you would find. The first one is a normal MFERG. Second one is when the patient is fixing not at the center. You can see that this waveform, this waveform at the periphery here is more prominent. When the patient is fixating, when the fixation is not proper also you can get an abnormal ERG. This is due to, third one is due to abnormal fixation, and the fourth one is when the trial frame placement is tilted. So I'll just briefly show you about VEP also. VEP is basically the response of the occipital lobe to flashes of light. So there is a pattern reversal VP and a flash VP which can be measured. So VP recording should be done with undilated pupils for pattern VP. Flash VP can be done under dilatation also, provided both eyes are dilated equally. You should not do it in a setting of anisocoria. When one eye is dilated and other eye, that will give you asymmetric results. And it has to be measured monocularly and with adequate refractive correction. With relaxed position, and sedation and anesthesia are not recommended for VEP. So I will not go into much details because I am already overshooting time. So to conclude, electrophysiological tests are objective tests, but patient cooperation is a must. Machine algorithms can help you smooth out the waveforms, but you should be aware to recognize the artifacts yourself. And the ISCV standards keep on changing every year or so. So you have to be updated, and you have to make sure that your machine at the hospital is also updated. Thank you.
I would like to invite Dr. Nimita Najee. She is the glaucoma consultant in Compass Eye Hospital, Calicut. She will be talking to us on automated perimetry. What's the right way of doing an automated perimetry? In the meantime, if anybody is interested to have tea, the tea is being served outside and in the dining area, or you can have tea and come back if you want.
So, visual field is all the space that I can see at any given instant, and Trakwar Hill of Vision is the island of vision surrounded by the sea of darkness. So, the boundaries of the normal field, visual field is 60 degrees superior and nasal, and inferior 70 and temporal 90, and blind spot is located temporally. There are two types of perimetry, that is kinetic and static. In kinetic, the testing is along the XY axis, that is from the non-seen area to the seen area, and the luminance and the size of the target is changed. Whereas in static, it is along the Z axis, and it is to determine the retinal sensitivity, and the size of the target is the same, but varying brightness. The different types of kinetic perimetry is Goldman, tangent and confrontation, whereas static is HFA and octopus. The unit of measurement of retinal sensitivity is in decibel, and increased decibel it corresponds to decreased light sensitivity projected. And the background illumination is basically 31.5 postals ASB, and the perimetry should be performed in a dim lit room and not in a brightly lit room. So this is how the screen looks like, and whenever the patient is seated, we give a central fixation target, and if there is a central scotoma, a large diamond or a small diamond is basically given. The eye monitoring is basically to locate the blind spot, and the center of the pupil should coincide with the video monitor, and if there is any head tilt, the blind spot is displayed, and if there is more than 20% fixation losses, it is considered unreliable. And in the newer HFA series, there is the gaze monitors, where it is in old HFA machines, this eye monitoring takes 5% of the total test time, whereas in newer HFA machine, the gaze monitoring is less. It takes each position, and the gaze monitoring is this is the below graph shows the gaze monitoring. So while we choose an HFA test, there should be a strategy, and that is, it should be a full threshold CETA or CETA fast, and then there is the program that is the 30-2, 24-2 or 10-2 macula, or then there is the perimetry techniques, that is either white on white or blue on yellow. And this is how the refractive correction should be given, that is full aperture lenses with narrow metal rim, which should be placed close to the eye, and single vision lenses and spherical lenses should be placed towards the patient's face, and cylindrical lenses towards the bowl. So these are the 10 zones which we take. So zone 1, it includes the patient data and the test data, and in the most common is that the age, all the details should be correctly entered, and the age, the size of the pupil is very much important, and it should, in older HFA machines it is manually entered, and in newer HFA machines it is automatically given. The refractive correction also should be given nicely, others it will lead to generalized depression. The stimulus size which we use is most commonly the size 3, and in advanced glaucomatous damage size 5. So this is a HFA of the patient where there is lot of fixation losses. So the basically this here I would like to highlight is that the wrong done here is that the refractionist has entered the eye wrong. So all the details should be entered correctly, as it will affect the printout. Zone 2, that is the reliability indices, that is, it includes the fixation losses and the false positive errors. False positive errors, basically the patient responds, pushes the button when to a non-projected stimulus, and more than 33% is unreliable, and false negative, it is to failure to respond to the brightest stimulus, and more than 33% is unreliable. So this is seen in basically in an unreliable, in a inattentive patient, or if the patient is fallen off to sleep. Foveal threshold, the normal foveal threshold is 32 to 34, and this is the HFA of where there is a high false positive, which is seen as totally white, and it's a trigger happy patient, and when the false negative is more, then there is a clover leaf pattern seen. So if there is a double excess in the fixation loss and false positive and false negative, it means the test has to be repeated again. So the raw data just gives the retinal sensitivities in dB, and 0 means no response to maximum light intensity, and 40 means response to dimmest stimulus. And grayscale, it is just to look for the general trends. The total deviation numerical plot, it basically gives the difference between the normal retinal sensitivity and the patient retinal sensitivity, and the difference, and it's the probability plot is just the total deviation numerical plot converted to based on the significant probability values, and darker the square, more significant is the defect. Pattern deviation numerical plot, it is to bring out the deep scotomas, and after taking the 7th best retinal sensitivity point, it is added to the total deviation numerical plot, and this is basically important in glaucoma and forms the basis of the glaucoma hemifield test. And its symbolic representation is given in the probability plot. The mean deviation, then the next zone is the zone 9, which is the mean deviation, which gives the overall severity of the field loss, which is represented by the height of the hill of the vision, and pattern standard deviation by the contour, and VFI is given in percentage. So the VFI is basically to detect the rate of progression. The zone 10, that is the glaucoma hemifield test, it just gives the plain analysis of the visual field test, and it is divided into 5, that is outside normal limits, borderline, abnormally low sensitive, abnormally high sensitive, and within normal limits. So this is a normal HFA of the patient, and the next is the glaucomatous HFA, and here you can see that in glaucomatous HFA it respects the horizontal meridian, whereas here there is the neurological defect where it respects the vertical meridian. So this is a small video of how to do the HFA. So after that's the headrest, chin rest and the adjustment buttons. You should clean and then you should select the strategy. You should select the eye first and then you should enter the patient ID, name, date of birth. Next, you should calculate you should enter the refraction details. The computer itself will calculate the trial lens. And next, you should enter the best corrected visual acuity. Followed by you should occlude the non-dusting eye and then you should explain the procedure to the patient. And after the chin and the head is kept clearly, then you test for the fovea. Foveal threshold is tested and then the main test is done. And then followed by you save the test and then after that the next eye is tested. Thank you.
The session deals with binocular vision assessment and orthodontics. And today here to chair the session we have Dr. Aditya Goyal sir. And to talk about it we have Dr. Anita Aravind. She is the co-founder and director of academics at Learn Beyond Vision. She has a strong interest in contact lenses and she is presently working as the head of operations and education at Optometry Council of India. So,